So, as you have heard, I am living here in Shepherdstown, but I work in Washington, D.C., and I don't have a lot of opportunities to talk to the community. So I think this is a really great opportunity for me, and I hope you enjoy what we're going to talk about tonight. So, without further ado, I want to make sure that you understand when we're talking about Ebola viruses, we are talking about one group of infectious organisms. And so when we use the word germs, there are all sorts of germs in the world. There are more germs than people. And there's actually more germs on your body than there are of you, believe it or not. But tonight we're only talking about this one category. So Ebola fits into viruses. It's not a bacteria or a fungus or a parasite or a prion. And if you ever, if there's any younger people in the audience or even older folks that want to learn more about germs, they're the most beautiful things to look at. You can combine science and your love of art if you're interested in infectious diseases. They really are fabulous under the microscope. So a little bit of background on Ebola, and this is a very beautiful photograph of the virus, and this is why it got its name. It's a filovirus, and you can see these little filaments that come off of the virus. And Ebola is actually one of many, many types of what we call viral hemorrhagic fevers. These are 4 different classes of viral hemorrhagic fever-causing viruses, and Ebola is caused by a specific filovirus with the genus name of Ebola virus. And it turns out there's actually 5 different Ebola viruses, but the one that's going around now is Ebola virus Zaire. So Ebola infection causes a very severe disease which is fatal in up to 50 to 90% of people historically. We'll talk a little bit more about how that might be lower when patients have access to better care, such as what we've been doing here in the United States. It affects humans and non-human primates, and it was first discovered in 1976 in a region of African continent that is now known as the Democratic Republic of the Congo. So I drew this line here because in 1976, the first time Ebola emerged, it was in this area. And since then, it has re-emerged at least 20 times, but always in this area, below this line. And what we're seeing now for the first time, and why it's making such news, and there's a few more other reasons it's making such news, is that it's the first time that it's ever emerged out of that area, and it's emerged here in West Africa. And it's also the largest epidemic we've ever had. So what about this emerging and going back away, this 20 times over a period of 40 years? Why is that? The honest answer is we really don't know. There are a lot of people studying this to try to figure out why it stays in nature and comes out episodically. And this cartoon sort of tells us the best of what we know so far. It's pretty clear from studies that the virus stays hidden in some species of bats. And we call this the enzootic cycle, where it just kind of stays in nature and is maintained in bats. It doesn't hurt the bats, and it may not get into any other animals other than the bats. But every now and then, an epizootic cycle occurs. And these are these little outbreaks we've been telling you about. So for whatever reason, the bat can then infect a chimpanzee or other wild game, and it can affect those, and they can become ill. But more importantly, when it gets to this animal, it's more likely to then jump into the human host by accident. And the reason for that are the cultural practices of the individuals that live in the countries in which this occurs. So you can imagine if these animals happen to be infected and just by bad luck, this family decided to game hunt and harvest the meat and be in touch with blood that's infected, they might acquire the infection. And that's exactly how these human epidemics occur. So this, as I said, the first outbreak ever in this region of Africa. It was confirmed for the first time in March of 2014. So it's been a really pretty long time now since the first case occurred. It's the largest in history, and it's really limited to 3 countries in West Africa. This is probably one of the most important points I'll make today, because some folks that haven't been to Africa or aren't as familiar with Africa forget that it is a massive, massive continent. It's a huge landmass. So when we say that there are risk factors for travel, it is not to all of Africa at all. It's really a very limited area. And this is a map of the continent of Africa, and we're talking about just this region in this red box. This is West Africa, and I've blown it up for you here. So if you take this little box and get a magnifying glass, you can see the 3 countries in which there's widespread transmission. So how many people in this area have been infected, and what context? Like, how can we put this in context of what we know from prior outbreaks? Well, in fact, it's more than all those prior 20 outbreaks combined. It's a large number of people, and that's why it's gotten so much press and attention. So if we look at Guinea, Liberia, and Sierra Leone, the three countries that have widespread transmission of disease, and we look from March to October, these graphs show you sort of how the cases have accumulated. So for instance, in Guinea, between March and October, we were up to 1,500 cases and 900 deaths. And this line was starting to eke up into a non-linear line. So for those of you all that like math, when we see lines kind of go like this and just add up, it's worrisome. But when we see a line take off like this, that's an exponential increase, meaning you're going from 10 to 100 to 1,000 to 10,000. And that's very concerning when you're trying to control an epidemic. So in Liberia and Sierra Leone, you can see that it in fact did look like we were getting this exponential curve. And this is when you started hearing about this much more prevalently in the news, and when you started hearing about us needing to make more of a response to help the West Africans get this under control. So if we look at all the overall case counts, there have been 10,000 cases and about 5,000 deaths. That's about 50% mortality, which overall is lower than most of the other Ebola outbreaks we've seen. It's usually been 70 to 90% in these other areas of Africa. And then there are other countries where a case may have moved out, so we call those travel-related cases, and that includes the United States. And then in some of these countries, there has been what we call localized transmission, meaning very, very limited to someone in direct contact with that person who traveled, which is very different than widespread transmission, where it's occurring all over the population. And so this is why we were so concerned. When we looked at that exponential curve and we saw all these cases increasing, we said, well, if we don't do anything, what is going to happen? And it turns out that worst case scenario, if we kept on that trajectory that we showed you that has occurred, we would have 1.2 million cases of Ebola in West Africa by January. And that's not very far away. So it was clear that we needed to shift the curve somehow and try to get it down to this best case scenario, where we only have 30,000 cases by January. That's still a lot of people, but 30,000 is a lot different than 1.2 million. So I want to show you some slides of what the conditions are like in West Africa, because this is the challenge to controlling the spread. This is actually a very nice, well-developed area. Some of the other areas don't even have this degree of development. They're just small villages out in the rural areas. This is an example of the signage that the World Health Organization and the CDC have put up so that there are pictorial reminders to people to present themselves for help. Even if they can't read, they can look at the sign and see that they need to let someone know if they're having these symptoms and not just stay at home. This is actually very typical of the conditions in a regional hospital. So compare this to the lovely healthcare setting we have here, even in a relatively rural area of the United States. It's like night and day. We don't have private rooms. There's no possibility for good sanitation. There's not running water. So it makes it very difficult to care for these patients. For the healthcare workers that come from developed countries to help these people, they do have the ability to use effective protective equipment, but the area that they have to work in is not at all like it is where we have the capabilities we have here. And one of the major challenges to controlling this disease has been burial practices, because just as in our country, people who are burying their loved ones want to touch that person. They want to hug that person. They have cultural practices about putting things into the areas that they bury them. And unfortunately, all of those things are ways to spread Ebola effectively. So one of the biggest barriers has been getting the trust of the people to let the U.S. and other international health workers who are coming in to help them with burial, and to give up some of their usual cultural practices so that they're not continuing to spread this within a village. So this is a very poignant picture of a woman who has done that, and she's trying to do what she would usually do, which is put some of the dirt from the area to bury her sister who's being carried away by strangers, which is a very stressful situation. And the heroes not only are the people coming from outside to help, but are the actual villagers themselves that volunteer to try to help the people with Western medical practices. So this is an example of someone from this remote village who's volunteered to learn the principles that we employ here in more developed countries, and he's out doing those things to try to help his village be saved. So let's compare that scenario that I just told you with what's going on in the rest of the world. So if we take all of the rest of the world, and this is a map, and each one of these little squares represents one person who's being treated for Ebola, the whole total is 18 people, okay? So I'm not saying that's not a tragedy and it's not scary, but it is a completely different situation than what's going on in West Africa. And if you only remember one thing tonight, that's what I want you to remember, that we are not in the middle of an epidemic here in the United States, but we do have an epidemic in West Africa. So if we take these 18 people that have been treated in other places, and we'll talk a little bit more in detail about the ones in the U.S., because of course that's the most interest to us here this evening. 12 have completely recovered, so that's a much higher success rate than we heard about in West Africa. 4 have died, and 2 are still in treatment and are expected to recover. If we take that all 18, there are 9 that have actually been in the U.S., and I want to point out that none of those 9 are people in the general public. 100% of those people that have either been transported to the U.S. or have been infected in the U.S. are direct contacts, are healthcare workers. They are not people out in the general community. And therefore, the risk really is incredibly low for the general population to worry about getting infected with Ebola. So the 9 Ebola cases that have been managed in the United States, there have been 4 actually diagnosed in the United States. One, I'm sure you all heard of in the news, was a gentleman from Liberia who came to Dallas on September 24th and unfortunately died eventually. The 2 healthcare workers who took care of this patient during the time that he was being treated have fully recovered, and I think you've seen in the news, one of them was released from our own NIH just this week, or last week, and the other was released from Emory, I think on Tuesday. There's also, you just heard in the news a few days ago, a healthcare worker who was in Guinea working and came back to New York City, who was monitoring symptoms, detected a fever, and is now being treated, and he is also stable. There are 4 other people that were infected and diagnosed, but they were infected in West Africa. They were not infected here. And they just were simply transported here because they wanted the access to the U.S. healthcare system, and we were able to deliver that. And they have all 4 recovered as well. So let's just talk now about these U.S. cases. The first 3 patients were treated in 2 of our 4 federally funded U.S. biocontainment facilities. So I think you all know, if you're in a rural area, we're very lucky to have a health system such as we have here in Berkeley County. But there are also designated areas in the United States that are specifically funded to take care of these very, what we call high containment infections. And so the first 3 treatment patients, both patients survived. There was no transmission to the healthcare workers. This is a picture of Kenneth Brantley, who was the worker who was infected as he was being discharged from the hospital. Everyone was elated that he did so well. Actually, he spoke directly with his physicians and learned a lot about taking care of these patients from Bruce Ribner, who took care of them. And you remember the media frenzy that was there. When I talked to Dr. Ribner, he said it was very difficult to get to work. There were tents outside, media tents everywhere that were very interested in seeing, how the patient was doing. And so I think after this happened, people were feeling pretty good about everything being in control. But then what happened, we all know about. And I put this sort of wordy calendar here, but I just want to walk you through what happened in Texas Presbyterian, because this is really what set up all the concern that we're hearing about now. So on September 18th, we talked about Mr. Duncan, who came from Liberia. He actually did what he was supposed to do, and when he developed symptoms, he went to be seen at an emergency room there. And in fact, they did ask the right questions, and there was a history taken. But somehow that message got lost and he was sent home rather than isolated. And he got much sicker, which is what can happen with Ebola virus infection. When he returned for care, they did pick it up and he was put into isolation. But unfortunately at this point he was extremely infectious because he was at a later stage of disease. And unfortunately, even though the hospital was putting into place what they thought were the usual preparations, 2 of the nurses that took care of him got ill. So when that happened, there was all sorts of media concerns about non-scientific things. So, wow, maybe we don't know anything about Ebola virus. Wow, maybe the CDC doesn't know what they're doing. wow, maybe this thing is mutated, and so these are the kind of things that got out into the communities and in the press, and you can imagine that really gets people very, very fearful. And this is what you saw in the media. Stop the flights. We don't want anyone coming to our country. Mass hysteria at hospitals. Red alert. 300 million of us are going to get Ebola. And this is the kind of news coverage that unfortunately occurred when these cases occurred. However, the CDC, their job is not only to provide sound medical and scientific advice, but to communicate that message to the public. And I want to walk you through what their response was when they found these unexpected cases. So the first thing they reinforced is that there is not an outbreak in the U.S., that these 2 cases occurred as a direct contact of a healthcare worker with a known patient. An outbreak is when you have spread beyond the initial direct contact, and that has not occurred, and we don't expect it to occur. However, they realized that these healthcare providers clearly must be at a higher risk, which we knew all along. So therefore, they said we need to get better prepared, and we need to go do a detailed investigation about why this occurred. So they asked very logical questions. What sort of personal protective equipment was being used at that hospital? Were the people trained properly? How are they taking it off? Because if it's contaminated and you take it off, then you might as well have not had it on if you're not taking it off properly. Do they need some changes in their training and their protocols? And all this has resulted in really a flurry of activity in the last 2 weeks, as I'm sure Dr. Simmons can attest to, where we essentially 24/7 have been updating guidelines, training our personnel to comply with new guidelines. So as recently as 9 days ago, we have much revised equipment, personal protective gear. We have expansion and very explicit directions now from CDC, not just sort of like, well, this is how to use it, kind of. It tells you line by line exactly what to do. And most importantly, I think for the general public, is there is much more aggressive active surveillance of travelers returning from West Africa. So whether you're in the camp of we shouldn't let anyone into the country from West Africa or not, I want you to understand that not only are people screened as they're leaving the country for symptoms, it's been recognized that there can be people missed that way because they may get sick later, right, when they get here. So when they are getting here at 5 major U.S. airports, which were selected because they cover 94% of the passengers, so we're covering basically all the people coming from West Africa. If they are ill, they are immediately quarantined. If they're not ill, there's active monitoring where the health department will go in and actively monitor them for symptoms. So this is a more effective way of screening patients, making sure that there aren't people wandering around in the U.S. potentially infecting people, but at the same time not cutting off the lifeline of travel to care workers that need to get over there and help the people that are truly affected. So every hospital has developed a very comprehensive institutional response plan, and you're going to hear about a detailed one here that's in place here. The point I wanted to make on this slide is this is a major effort. This is not just putting on PPE, personal protective equipment. It impacts every single thing we do in a hospital. We have to have our lab on board to tell them how to safely run labs. We need to have our radiologists know how to do x-rays and dedicate equipment. We need a media plan. We need ways to support our family. Can you imagine how stressful this is when we put someone in isolation just because we ask them, do you have a fever and have you been to Liberia? And what else are we doing? The plan itself is not enough. We are actually actively screening every single person who walks into the hospital or as a visitor. We ask them a series of questions. We don't want to miss anyone. We are doing active drills every day, pretending that there's an Ebola patient so that we're prepared. We actually are doing work with our local and federal legislators. So I testified for the D.C. City Council. I give statements to the Congress. So we're all working with them so that they're making decisions based on science, not based on fear or hysteria. This is an example of the protective gear, and I think you're going to talk a little bit more about that. But just so you know, there are different levels of gear, and now with the latest recommendations, we're all on this side of the picture. And this is an example of the tool that if you walked into Children's Hospital, the minute you hit our information desk, someone would ask you, within the last 21 days, have you been to one of these countries? If you said yes, we would ask you about symptoms. And if you said yes, I would get paged, and I would walk down and we would deal with it. So most hospitals have this in place. We have this in place in every clinic, every part of our hospital. And we have signs up all over the hospital, too, so that people who aren't aware could read this sign in their native language or in English and come up and ask us, what's this about? So the last thing I want to talk about before I hand it over to Dr. Simmons is understanding how it causes disease. And we really do understand this. It's been around for 30, 40, 50 years. We've studied it very carefully. And we've also done genetic studies on the virus that's circulating now, and it hasn't changed. It's the same virus. So I want to allay your fears if you're hearing that something has mutated or changed and this is some new strain. It's not. So it infects all sorts of cells, and for that reason it can cause lots of organs to be infected, and these patients can be very, very ill. So ill that probably in areas that don't have critical care abilities, so intensive care units, it's very difficult to save the lives of these people. That's not the same as in the United States. They also have massive fluid losses, so they can lose 10 liters of fluid a day just from vomiting diarrhea. And they can also lose fluid within their blood vessels because the blood vessels become very leaky and leak out fluid. They have electrolyte abnormalities, so their sodium, potassium, and magnesium gets off whack, and then they can have arrhythmias and their heart cannot work properly. But these are all very general things that we see in all kinds of infections, and we're very good at supporting people through these in the United States. So I'm going to skip that. So our usual treatment is supportive care, meaning we give them fluids. We measure their electrolytes. We replace them as need be. We give them oxygen. We give them blood pressure medications. We'll treat other infections if we have them. And there are experimental therapies which are in very, very early stages, and to be quite honest, I don't believe are going to solve the problem in West Africa right now. But just so you know, you may have heard of ZMapp, and this is a kind of a protective antibody cocktail. There's 3 different antibodies that are put into this that block the virus from infecting cells. But unfortunately, it's really early in development. We've pretty much exhausted the supply of it, other than starting to do some new studies on it. And the Health and Human Services is working with the company to try to expand the production so that we can do some kind of accelerated clinical studies and hopefully be able to use this soon. The National Institutes of Health and the Department of Defense are working with 3 different companies to come up with antiviral treatments that will specifically kill the virus. And then we just finished a phase 1 vaccine trial that was spearheaded by the National Institutes of Health in healthy volunteers, and it actually looks safe. So it's just about to expand into a much larger study in West Africa, in the country in which it's most needed. So the bottom line for controlling this is on the ground in West Africa. And I put this slide in to remind you of all the things that the CDC does. They are actually on the ground with 150 young people that, including one of the people I just trained last year who joined the CDC Epidemiologic Intelligence Service, that go out there and literally knock on every door, every hut, and find contacts, because that's the only way that we will control this. So this is an example. Could be my trainee who's out there finding people and giving them information, getting them to treatment, and isolating them so that they don't infect further people in their village. Doctors Without Borders is one example of another group. There are 700 that have been sent out to West Africa since March of 2014. Even in those conditions that I showed you in the picture, they are very good at preventing infection in their healthcare workers. So only 3 have contracted Ebola from all those people over a long period of time. So education in how it's transmitted is very important. And really, our job here in the U.S. as well as in West Africa is to find cases, isolate patients, educate them on how to prevent further infections. And most importantly, we want to remember that fear is far more contagious than Ebola virus. We can fear or we can care. This is really our mantra at Children's National. We're human beings too. It's scary when you first hear about this, but you need to be logical. I tell my kids this all the time. If you panic, you can't think clearly. So you need to think about science and facts, and we can care for these patients. And this is my last PR statement for the evening. Influenza kills 30,000 people in the United States each and every year. 30,000. So get your flu shot and worry about flu more than worrying about getting Ebola in the United States. Thanks a lot.
First of all, I'd just like to thank Dr. DiBiase. Very good talk and very informative, so I'm very pleased that we were able to get her here. So the first thing I want to tell you is the first message that you're going to hear a lot of us talk about is to stay calm. And really, that's the important thing you need to do. I just want to reiterate that the people that have been exposed and contracted Ebola in the United States were healthcare workers who had direct contact with active patients. A little caveat to that is when we talk about active patients, we talk about people who have shown symptoms of Ebola in a very specific stage of the disease, who have the GI syndrome and are having a lot of fluids. So if I'm standing up here with Ebola right now, don't panic. I'm not. You're not going to get it from me. The CDC has very clearly designated that you have to have direct contact with fluids of a person. And so we want to just reiterate that going to Martin's, going to wherever you're going to go, is very, 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 one more very, low risk for acquisition of the Ebola virus. Okay? So what you need to know is that hospitals have been preparing for the eventuality that a highly contagious or severely contagious disease would reach our shores eventually. Okay? It's not an if, it's a when. And we knew that. And so we had some background that we knew what we were going to do. But what you need to understand is that we've never had transmission of this viral hemorrhagic fever, this strain of Ebola in the United States. So everybody was very quick to jump on the case of Dallas and say, they did so many things wrong. But the truth of it was they were the first healthcare facility in the United States to have transmission of the virus. And for the many, many, many people that took care of Mr. Duncan, only 2 healthcare providers had acquired the virus, which shows the things that we were doing, even without a lot of experience and exposure to the virus, were working most of the time. So what you need to understand, though, is that West Virginia University healthcare systems, including Berkeley and Jefferson Medical Center, didn't just start the Ebola plan last week. We didn't start it last month. It's been going on since there was continued transmission of the virus between human hosts in West Africa. And it's because healthcare really is a global thing. You know, we don't live that far from an international airport. And not to scare people, but you need to be aware of the fact that I could be from China to Martinsburg in a very short period of time. And so that's why you're seeing the globalization of infectious disease. So our plan takes into care of that. So the first thing you're going to see is when we talk about preparedness, we realize that at Berkeley Medical Center and Jefferson Medical Center, we are not Presbyterian. We're not NIH. We are not, even Dallas. We're Berkeley Medical Center. But that doesn't mean that we don't have a plan. And we do have a very thorough plan that has been discussed with multiple places, including the local, state, and federal people involved with this, including up to the CDC. So what you need to understand is that hospitals are stratified into level of care, okay? You have first level, primary level, secondary level, tertiary, and now quaternary care. And as you go up higher in the number, that means they can provide more services and have more specialties and are just bigger, okay? Berkeley Medical Center is not a tertiary care center, okay? We know that. WVU, Cabell Huntington, Charleston Medical Center, these are tertiary care centers, multiple specialties and subspecialties. But what you have here is a very good secondary level care hospital. And I want to reiterate that again, just for those of you who have some doubt, this is a very good health care system, okay? We take care of things within the same guidelines that other people do. We follow national guidelines. So when we started talking about this plan, we said, well, how are we going to make sure that we provide you, the community, with the best outcomes that we could? And the first logical step is you say, well, if I could be at a secondary level care or I could be at a quaternary level care, I probably want to be at a quaternary level care if I have something very seriously wrong with me. And that's good logic. You know what I mean? If you have something very big and bad and scary that requires a lot of specialists, you need to go to a quaternary level care. So that's the first thing we started talking about. And it happened on a state level. The West Virginia state government has gotten involved and said, we're going to designate hospitals based upon where you are in the state that are your tertiary care level centers, because there are not that many quaternary care level centers out there, okay? Now, the closest one to us in the state of West Virginia is Ruby Memorial, West Virginia, the flagship, the mother in Morgantown, okay? So we say, okay, if you come into our hospital and you have signs and symptoms, we're going to transfer you there. And that's how we're going to start the process, which is we're going to get you to a tertiary level care center, and then on from there onto a quaternary. And you see, that's a lot of movement. Why? Again, as we move through the levels of complexity of care, you start seeing subspecialists, more isolation possibilities, and then more support system. And really, what happens in Ebola is not something scary that we've never seen. It's just a lot of things that happen to the body at once, and it requires a lot of care. So we started talking to the CDC early. In August, we started talking to some contacts in the CDC. And where you see a lot of confusion is that the plans have changed. And what has happened is we've learned a lot more about the virus very recently. And remember, this is the largest continual transmission period of Ebola Zaire that's ever occurred in history. So we're learning more and more about the disease. And as we learn, we're updating it. And it shouldn't be seen as confusion. Healthcare doesn't know what they're doing. What it shows you is that we're learning on our feet. We're staying as close to being ahead of this as possible. We also realize that we have to educate nurses and providers on the personal protective equipment, because even though we use personal protective equipment every day, we don't use this high level of personal protective equipment consistently every day. And I'm going to explain to you why that's a little bit hard, because of the process that it undertakes. It takes about 15 to 20 minutes to put it on correctly, and about 25 to 30 to take it off correctly. And it requires more than just you. It requires someone to help you. And we also realize that we have to coordinate with the community. You know, it's not just the hospital. It's a continuum of care. Anybody that's in healthcare that's in your community is part of your continuity, your continuum of care. So EMS, your doctor. You know, a lot of you have a local doctor here in town. We need to make sure that that doctor understands what we're doing so that we're all on the same page. Education is the key to ending transmission. So you need to understand that every hospital in the West Virginia University healthcare system has its own plan. Those plans are individualized to the potential that that hospital has, the personnel that it has, and the capabilities that it has. But then, above and beyond that, all those plans have to fit into an umbrella that fits under the West Virginia University Healthcare Systems Plan, which means you can have your own plan and you can have your own little warbles and unique things about it because of your plan, but you have to satisfy this standard of care, which is the West Virginia University Healthcare System standard of care. Okay? And the providers that have their private practice doctors, maybe your doctor is a community doctor who has privileges at the hospital, maybe they don't. Though they still have to have a plan that all feed into this. So as you can see, as Dr. DiBiase was saying, there's a lot of coordination that goes on. This is a lot of tying a lot of things together. So what you need to understand is that every day, all day long, myself and Barb Sherman, who is assisting me as the infection control practitioner at Berkeley, and Paula Donahue at Jefferson, get calls all day long from the local and state health department updating us with things that are going on. And then weekly, we have calls between all the health hospitals in the healthcare system. And what we do is we check in with one another and we say, hey, we've learned that if we do this, this might get us through the flow of patients out of the ER quicker. And we share those ideas. And so it's not just Berkeley Medical Center has their plan, and it's a good plan. Well, I think so because I came up with some of it. But there are other hospitals that have their plan, and we're sharing ideas, which means there's a lot of very smart people sharing a lot of very good ideas, and you're seeing some of the discrepancies disappear as people say, well, here's the questions we were asking. Here's the questions we were asking. Well, why don't we just add the one question that we have different together, and we'll all ask these questions. What you also need to know is that the state has decided that they're going to set up a rapid response team, which means the state of West Virginia said, it's not that we don't trust you, but we want to take care of our patients and our citizens. So we're going to come up with a response plan that says that if you come into one of our hospitals and you have symptoms that we think are suspicious for Ebola, we're going to step in and we're going to assist your hospital. So there's another layer of very intelligent people who do things all day long saying, we're going to come in and help. And we're going to move these patients to higher level areas of care if it's necessary. And we're going to help you do that in a safe way so that EMS is not at risk, the patients in your hospital are not at risk, and your care providers are not at risk. And then the CDC says, if you have a case, a confirmed case, we're going to step in and we're going to move them to another level of care so that we're going to take care of that because we're the experts. We do this all day long, every day. So you kind of get bumped up through these levels of care, moving people deeper and deeper into the healthcare system where people who are more and more specialized with this deal with it every day. Okay, so now what you need to understand is that at Berkeley and at Jefferson, we've been doing numerous educational opportunities for our providers. And that starts with things as me, as the ID doctor, getting up and talking in front of the doctors, saying, giving them a lecture very similar to what Dr. DiBiase just gave you. This is what Ebola is. Because remember, doctors in the United States haven't seen Ebola before. And though they probably have learned about it somewhere, we need to make sure that they know the level of care that they need to know, the level of detail. Because you're going to come in because you're good consumers of healthcare, and you're going to say, I watched Anderson Cooper, and Anderson Cooper said, this is what I need to know. So we need to know that what Anderson Cooper said, and we need to know if that's right or not, and also how to answer the questions that it formulated for you. And so what we do is we use information from the CDC, the World Health Organization, NIH, all these things, and we take them and we say, here's all this knowledge. We're going to boil it down to the level of knowledge that you need to know as a provider. Now, I, as an ID doctor, and Dr. DiBiase as an ID doctor, need to know a lot more than other doctors. But we make sure that everybody that's in any flow of care knows the basic proper things. We've also decided that we're going to train people at every level of the patient experience to know the right questions to ask. If you walk into Berkeley Medical Center, if you walk over there right now, you'll see red and white signs everywhere that say, if you've traveled to these countries and you have these symptoms, or you know somebody that has and you have these symptoms, call this number right away. And all of our patients that come in through the hospital now are being screened at every point of entry. Points of entry are how you get into a hospital. Registration, the ER, same-day surgery, the clinics. People are going to be asking you these questions. And it might seem strange to say, well, I live in Martinsburg. Why would you ask me if I've been to Guinea? And I'll say, because out of all the people here, maybe no one's been to Guinea, but maybe one has. But if I don't ask every single one of you, I might miss, because I don't know who's been to Guinea. So it's called sensitivity. The more sensitive your question, your screening tool is, you're looking for asking a lot of people questions. You want to make sure that you get any possibility, okay? We've also worked with EMS. Our county and local EMS have also started asking these questions. And they started using the same questions we did, which were determined based upon what the CDC had asked us to use. So now we have a whole bunch of people asking the same questions. Why? Because that's the different ways that you get into the healthcare system. So we don't want to miss any way. So anyway, if you show up in my hospital at any time, someone's going to ask you. It might be me. It might be the nurse. It might be the dietary person that brings you your tray. But I guarantee you, right here in front of me, and you can come up to me later and say, Dr. Simmons, that's not true. And I'll find out why they didn't. Someone will ask you. I promise you. Okay? We have in-house education for our staff in what we do waves of education. This is a lot of information. It's a lot for people to take in. So you have to say, well, we're not going to dump all this education on you right at once, and you're not going to remember it. Because the average person starts to drift off somewhere about now in my lecture. Okay? And they're like, oh, he's talking, and I don't know what he's talking about. Ebola, Ebola, Ebola. What's on Scandal tonight? That sort of thing. So we give multiple opportunities to give people a chance to get educated, because studies show that repetition of the same information over and over makes you learn it. Okay? So we also have town hall meetings between leadership. Last week, our COO, Mr. Zelinka, had a meeting, 3 actually open hall meetings, where people who work in Berkeley Medical Center could come in and say, I have questions about what we're going to do for Ebola. So we started there. because we wanted to make sure that we addressed the questions that the people that work in the hospital have, because we knew we were going to ask you. Because this is all new and we're learning together. And even though we know what we're doing, doesn't mean we can't get better. Why settle for an A if you can get an A+? So we have set up meetings, weekly meetings of our Ebola task force. And what we did is basically took every department in the hospital and designated somebody that comes. Engineering, housekeeping, dietary, radiology, emergency room, nursing, physicians, administration. And we said, come to this meeting and we're all going to talk about what we're going to do so we can all be on the same page. Okay? Marketing has been involved. I don't know if any of you heard, but I was on the radio a couple of weeks ago talking about be calm, don't worry about it. It's going to be okay. We're trying to give you a consistent message that we are paying attention to your needs and your concerns, and we're taking into consideration the things that you're asking. This is why we're having this thing tonight. You wanted to know more. We heard you. We're going to tell you more. So, before I go on to Jefferson's, I want to tell you a little bit that's very specific about Berkeley Medical Center. One, we have meetings about this every Wednesday with EMS, with the fire company, with the police, with external sources and internal sources. We're reaching out into the community, contacting people saying, here's what we're doing. Since we all share this space together, let's all be on the same page. What you also need to know is that Berkeley Medical Center has designated an area and created what we call our severely contagious disease unit, which means we have a room in a certain part of the hospital that has the ability to have negative airflow so that the air from that room doesn't go into the hospital. It has direct access to the outside so that person comes right into that room and doesn't go through the rest of the hospital. That room has an area where healthcare providers can put on their protective equipment, an area where they can take it off, and that's separate. It has a shower that the healthcare providers then can shower to make sure that they're not contaminated. And there's a separate area where the patient is being kept in a room that's sealed off, protected by machines that keep the air from circulating around the hospital, that keep the fluid in the area so that if people are having up to 10 to 15 liters of diarrhea, it's not getting out and contaminating the area. We've also decided that we're going to keep it under a locked area so that only people that need to be there are going to go in and out of that. So you're not just going to say, well, Dr. Simmons, I'm really worried. I'm just going to be walking down the hall and just walk into your severely contagious disease unit. I promise you that's not going to happen, okay? What you also need to know is that there have been a lot of things that have been going on that continue to go on where we reach out and to make other connections. Berkeley Medical Center is reaching out to other places. We're very fortunate to have the resources like Dr. DiBiase with a wonderful resource at Children's National, where you're seeing healthcare networks working together more than they ever have before. Jefferson is in Jefferson County. It's also part of the West Virginia University healthcare system, and they're sending out emails to their associates letting them know. It's a smaller hospital, so they have some benefits of more direct contact. But they've gone above and beyond that, saying we're not just going to guarantee that. We're going to send electronic so that people know and know that any changes. And they are doing the same things that we are. And you're going to see a lot of repetition between when people talk about it in the system, because that's good. What you need to worry about is process variation. We're getting rid of process variation, which means we're streamlining how things happen. If everybody does something the same way, and it's the best way, you get the best outcomes every time. Okay? Again, you're seeing a lot of people asking questions at the ER as you're coming in. Do you have these symptoms? Jefferson is also doing that. You're going to see a lot of repetition because these are best practice. In medicine, we focus on things called best practice, which means of all the ways to do things, this is the best way to do it. So we're all striving to do it that way. These people then, as they're asked the same questions. Have you traveled to these countries? Do you have these symptoms? And if you have, they notify their Ebola response team, as we do, and you get moved to an area of isolation. So the good news is that if someone would show up the ER at Jefferson or Berkeley tonight with Ebola, you wouldn't be sitting in the same ER open bay with them. They would already be moved. They'd be moved, and you wouldn't be, like I said, if you're sitting across the aisle from somebody, you're probably not going to get it. I won't say 100%, because nothing in life is 100% except death and taxes. But you're going to get moved into. They're going to get moved into a safe place. Okay, there's a dedicated team of nurses and physicians at both facilities that are being trained above and beyond what everybody else is doing. Berkeley Medical Center has designated 15 nurses from their ER and ICU core staff that are getting a secondary level of training, which includes more drills on how to put on and take off personal protective equipment, how to respond to that, and how they're going to cover it. We've come up with a plan of how long they're going to be in the room in their protective equipment, how we're going to rehydrate them because the suits are hot, where they're going to go when they're not taking care of the patients. There's a lot of thought that's gone into this. Jefferson has done the same thing. They've talked about their dietary needs. How are the people that bring you your food? How are they going to get there? How are we going to get radiology? Labs. We've moved on the system level to what we call point of care testing. If you come in and we think you have Ebola, we're going to put you in this room. We're not going to take your blood all over the hospital. We have the capability to do 15 to 20 labs right there at the bedside so that we don't have to take the blood out through the hospital and risk exposing people. We're minimizing the chance of exposure. So what I want to tell you is this very small risk that you have, we're minimizing even more. And that's really what I want to focus on. These procedures are not, this is not a 90% chance you're going to be exposed to this. This is the chance of winning the lottery, and we're going to make it even less likely that you're going to win the lottery right after you get struck by lightning. That's what we're striving for, okay? And one of the things that we've done, we've said, okay, we're all going to use this type of protective equipment. We're all going to go use this type of suit called a Tyvek Tychem suit. This suit is so good that they use it in the petroleum business to protect people from chemicals. It goes from the head all the way down to the feet. We have enclosed feet. We have the hoods down over, taping the seams with oxygen inside of the system to protect the nurses. Again, I want to protect each and every one of you. But the good news is that the very nature of this disease is protecting you. What I have to do is protect my nurses, because they're the people that are going to be exposed. So, I'm not telling you to run out and get on Amazon.com and buy your Tyvek suit. I'm telling you that we looked at 17 different types of suits to make sure. I want to reiterate to you, this is not something we've done off the cuff. There's been a lot of preparation. Several people have spent all day long, every day, for months, making sure that you have the best response teams that are possible. I will gladly tell you that, are we more ready than we were when it came to Dallas? Yes, absolutely. Any hospital in the United States is more ready now. And think about, again, how well Dallas was doing based upon what they had. We learned important things like, you can't have this space here between your suit and your hood. So all of a sudden, you see the hoods are now longer. We're learning. So those small chances get smaller every day. We also have all the nurses that are going to go in and out of the rooms. We have all their information so that we know where they travel to, who they're going to be in contact with, anybody that goes in and out of that room. I'm sure I'll be there. I'm the infectious disease doctor if it happens. So they have all my contact information, where I go. And we're going to tell you, if you're caring for this patient, we want you to stay at one of two places, the hospital or home. So don't worry, I won't be out running around in Martin's if I'm taking care of an Ebola patient. Lab specimens have a dedicated route that they make it into and out of testing. We've already streamlined the process of how blood work from a sample patient goes to the CDC by a protected courier, how we get a response back, how the fewest people are exposed to that blood as possible. We've also talked to the local law enforcement saying, look, we realize that people are going to be scared, and it makes sense. If someone told me that there was an Ebola patient over at the hospital right now, I would be scared. Even though I'm telling you, don't be scared. it's still a scary thing. You know what I mean? I realize that I can stand up here and say, don't be scared, don't be scared. But I realize you're going to be scared. So we're going to make sure that you know that there are people out there who are trained to deal with this, that it's going to make it safe for you. The other thing that I just really want to emphasize is what you're going to see now is the healthcare system evolving. What we do very well as a profession is learn on our feet. Better, I would say, than just about anybody, because we do that. It's how we do these things. We learn every day. New drugs come out every day. New diagnostic tests come out every day. We're learning on our feet. So anything that I say tonight doesn't mean that tomorrow, next week, we won't have a better answer for you. And when that happens, we'll tell you. We're going to be honest with you. It's transparency. That means if any day of the week you have a question, you have a concern, if we think that we can address it, we're going to address it for you. Now, that doesn't mean I'm going to call each and every one of you and say, hi, this is Matt. Remember I told you I was going to call you? No. But we'll make it available. There will be news articles. There will be radio articles. There'll be more things like this. And I'll continue to give you education. I want to leave you with one thing tonight. Please, please, please don't worry. I tell my patients this all the time in the hospital. You come to a doctor so you don't worry anymore. You let the doctor worry for you. I'm telling you here, don't worry. I will take care of you and my community.